Good to see you all again with another video. And this video is about impetigo. Impetigo is a type of superficial skin infection. And if you want to know about the different types of skin infections, you better watch the types of skin infection video prior to this. You can get a clear understanding about the types. This is the first video of the skin infections where we're going to see about impetigo. Impetigo is actually a bacterial infection of the superficial skin. The superficial skin, which is above the dermis, the epidermis, that is the keratinized layer. So this impetigo is the infection of the keratinized superficial layer of the skin. So we can for an extra point or something, we can see about the etymology, which means the origin of the word impetigo. The impetigo word has been origined from a Latin word called impeture. That impeture means to attack. That means the skin infection spreads rapidly, and this is not more serious, but it spreads rapidly over the surface area. So they had named it in the past medical terms as impeture, and from the name has been followed and came to a word called impetigo. So we can look up into the condition. So this impetigo can be divided into two types. One is non-bullous impetigo and the bullous impetigo. So the non-bullous impetigo accounts for 70% of the cases, where bullous impetigo accounts for only 30% of the cases. These non-bullous impeticos can be caused by two different mechanisms. One is primary and secondary. The primary one occurs in an intact epidermis, where the secondary one occurs after a trauma or a skin insult. So what are the organisms which are going to cause this non-bullous impetigo? The major causative organism is Staphylococcus aureus, which is found in the normal flora of the nasal cavity. So you can correlate with the location where this non-bullous impetigo causes, which are near to the oral cavity and these nasal cavity areas. So this is the most common one and most probable one to cause this. So also, if you see the clinical feature of the non-bullous impetigo, that is also mainly occurring around the mouth and nasal areas. That is the most common location of the non-bullous impetigo, rather than the bullous impetigo, which can be seen in the extremities and the trunks as well. So these Staphylococcus aureus is the most common organism. The second to Staphylococcus aureus is group A hemolytic streptococcus. This group A hemolytic streptococcus is normally colonizers in the skin, then causing the non-bullous impetigo. So prior to this infection, around approximately 10 days of colonization can cause this infection, either primary or secondary way. So so the secondary way, which are traumatization of the skin, can be caused by either insect bites, abrasions, lacerations, chickenpox, scabies, and also burns as well. All these can cause the secondary trauma to the skin. After this trauma, the invasion of these organisms, the pathogens, can cause the non-bullous impetigo. So if we see the clinical picture of non-bullous impetigo, non-bullous impetigo will appear like vesicles, papules, or pustules. Then they will be bursted. Once those papules and pustules bursted, they can form a honey-colored crust. So this honey-colored crust can be painful and itching as well. So itching further make more traumatization and more spread of this infection. And also this can cause regional lymphadenopathy as well, and also systemic infective features like leukocytosis also can be seen in primary or a secondary non-bullous impetigo. So the next one, the bullous impetigo. The bullous impeticos accounts for, as we see, 30% of the cases. These mainly affect the infants or young children. So most common pathogen is Staphylococcus aureus, but here the exfoliating toxins found in these pathogens like ETA, ETB, or ETD. You can remember like the alphabets, first 3 4 letters of alphabets without C. So these toxins hydrolyzes human desmogletin 1, which is found in the skin. So these intact skins exposing to these toxins will lead to hydrolyzation of desmogletin 1, which will lead to blisters. These will be flaccid, fluid-filled blisters. Once after maturation, they will rupture. Once they rupture, they will form a narrow, raised, scaled edges and will form a brown color discoloration. But typically, they will not form lymphadenopathy or erythema around the surrounding area. So, in this picture, you can see the child is having as mentioned, a flaccid fluid-filled blisters around the area, but most commonly this will be on the trunk and extremity areas rather than around the mouth and nose, which is typical for non-bullous impetigo. And surrounding erythema and regional lymphadenopathy will be usually absent in bullous impetigo. Looking at the complication of impetigo, impetigo can cause bacteremia, but it's very rare. So other complications can be osteomyelitis, septic arthritis, pneumonia, septicemia. These also can be caused, but these complications are rare phenomena as secondary to impetigo. And cellulitis also rarely reported, around 10% of the patients. And there's another complications which has some significance, which is post-streptococcal glomerulonephritis, which can be caused secondary to this impetigo infections, uh, around 18 to 21 days post-infection, which can be a little bit longer than the 10 days post-infection of a pharyngitis. So it's good to remember the complications, and we can move into the treatments. Treatment options either can be topical or systemic. Topical, we can consider mupirocin 2% or retapamycin 1%, which can be applied 2 to 3 times per day for 2 weeks. Systemic therapy is considered when the lesions are around the mouth and the local application is often licked off by the child, or either there are complications like deep tissue involvements, cellulitis, bronchiolitis, abscess formation, and suppurative lymphadenitis is noted. We can go for the systemic therapy. Systemic therapy, we can choose for cephalexin 25 to 50 milligram per kg for 7 days, but it's always better to take a culture prior to starting IV drugs, and can change the antibiotic according to the culture specificities. If MRSA is found in the culture, we can go for clindamycin, doxycycline, sulfamethoxazole, trimethoprim. So that's all for today, and we'll meet you in another video. Thank you. Bye bye.